right. Good morning and welcome to the CTSNet Roundtable, Fostering an International Perspective on the Cardiothoracic Team. My name is Jill Lay. I'm the Clinical Nurse Specialist for Surgical Services at California Pacific Medical Center in San Francisco. I'm joined today by Dr. Patricia Keegan, Director of Strategic Initiatives and a nurse practitioner with the Emory Structural Heart Team in Atlanta, Georgia. Also Tara Bartley, the lead advanced nurse practitioner at the Queen Elizabeth Hospital in Birmingham, United Kingdom, prior chair of the SCTS Allied Health Conference, and also a fellow of the Royal College of Nursing and an officer of the Order of the British Empire. Also Joel Dunning, a thoracic surgeon at James Cook University, Middlesbrough, United Kingdom, and editor of CTSNet, and Richard Van Valen, a certified nurse practitioner in cardiothoracic surgery from the Netherlands, also is chair of the Allied Health and Nurses Commission for the EACTS meeting annually. We're here in Fort Lauderdale, Florida at the 54th Annual Society of Thoracic Surgeons meeting, and we want to ask these speakers about their presentations yesterday. We had a wonderful session, and I'd like to start with Tricia. You described an evolution of your structural heart team at Emory. Could you tell us how that evolution occurred and who's on your team?
Absolutely. Thank you for inviting me to be here today. So when we started off, the transcatheter aortic valve replacements were only available within clinical trials. And so our team was very small. It was made up of surgeons and interventional cardiologists, but really nobody else. And as the program grew, and as the valves started to become towards commercialization, they realized that the team needed to expand. And at that time, we started adding imagers, our advanced practice providers, as well as a valve clinic coordinator who was there to kind of tie all the pieces together and make it so that it was safe and efficient for our patients who were coming in, that they would get all the testing that they needed and that they would be taken care of every step along the way.
And you also described during the procedures, there's fewer people in the room these days. You've sort of minimized things. How did that evolution come about?
Absolutely. So it was, as our team grew, the amount of patients grew as well. And also we had to look at ways that we could become more efficient with procedures in the room. And one of the first things that we did was looked at the staffing in our cath lab and in our hybrid ORs, and we're able to pare that down to basically 3 cath lab staff and 1 nurse within the program, as well as the imager, the physicians, and we're able to do the procedures with the same safe outcomes that we were used to with a much larger team.
That sounds great. And Joel, you showed us a variety of robotic and minimally invasive thoracic procedures that have now become quite common at your organization. Who's on your team and how do you prepare them to do novel things that haven't been done before?
So surgeons historically have taken on new procedures on their own, and we need to really get away from this because technology is quite complex, you have got to come with a team. Robotics cannot be done as a single person. So in our team, when we started robotics, we took the whole team to do the training because I needed to have a bedside assistant and I need to have additional people around us. And then when we come back, we did a simulated operation with our teams together. And it's absolutely vital, whatever you're doing, whether it's robotics or TAVR or new procedures, get out of your silo as a surgeon and make sure you know that there's a team working with you. It's absolutely vital. And I actually love your point that you should actually reduce the number of your team, because when there's a new procedure going on, the world and their wife want to come along, don't they? So actually make sure you know who's on the team, value them, and practice with them. And that's what we did in robotics.
Sounds like it was very effective. Tara, you shared with us a standardized nursing education curriculum that's now being utilized at centers across the United Kingdom. Can you tell us how that collaborative project developed and how you determined the content of the education?
Thank you. Good morning. So our undergraduate and postgraduate nurse training in the United Kingdom has quite a generic aspect to it, and it came to light that obviously within the speciality, a more detailed assessment of what was needed to underpin clinical care was what we wanted to look for. So under the auspices of the Society for Cardiothoracic Surgery, myself and surgeons and allied health professionals such as surgical care practitioners have put together a whole education portfolio that is a multidisciplinary education program, a number of different courses. Some are specific according to speciality and the level at which somebody is sitting, but some of it's multidisciplinary. So within the ones that are applicable to the nursing and the allied health professionals, we've put together a whole portfolio that includes how to set up an allied health professional structure itself within the organisation, and that looks at the business organisation, the strategies that are involved, and the educational components that are required in terms of competencies and skill sets. And then we spend some time reflecting on people who've actually been through the process so that they can share the troubleshooting and the learning that they have got. The other courses are more clinical, and they are around looking at various different levels of nursing to provide them with anatomy, physiology, pathophysiology, and then under sort of the ways of learning that we've found research-based has made it a very good way to internalise and then impact on patient care. Our courses are a combination of wet labs where people, even if they're not doing the procedure such as mitral valve repair, have a go at the stages that are involved, and that allows them to have a greater understanding of what their patients have been through and what needs to be done from an anatomical point of view looking after somebody. And then we have workshops, and the workshops are small scale, they're fun, and they allow people to interact on such things as clinical examination, listening to heart sounds, being able to interpret various types of imaging. And the whole essence of the courses are around fun and internalising the learning and being able to then share that with colleagues. So they're very popular courses, from the nurses that are working on the wards to the nurse practitioners to the surgical care practitioners, and any courses also invite pharmacists and our physiotherapy colleagues come, and we often, the level at which we run them, we often have the more junior doctors arriving as well. There is a portfolio that covers the more senior doctors, and they look at clinical but also professional aspects.
And so you gathered clinicians from all over the country to sort of agree on this curriculum and sharing. That's pretty unique, something I don't think we've seen too much of in the United States. Richard, I'd like you to comment on you discussed yesterday the benefits of negative pressure wound therapy on sternal wounds. How did you develop this project, and who would be involved in implementing a change on your team?
Well, it's a good question. Everybody is involved with patients who develop complications, and wound complications are among the most detrimental a patient can have, both physical but also mentally. Reducing the number of wound infections has been, for almost everybody involved in cardiac or thoracic surgery, a major point, and we have learned that not a single intervention will reduce the number of wound infections, but that care packages and a lot of different interventions can help. And this idea was formulated quite a long time ago, and in the Netherlands we have quite a good system when it comes to these kind of problems, that not only surgeons are invited to think along, but also nurse practitioners, as I am, and nurses who are involved in wound care. So it was a couple of years ago that I and a colleague were invited to join the project group, and we, together with surgeons from all over Europe, devised a protocol how to use such a device, but also how to select the patients. Because it's a device with a certain price tag on it, and you shouldn't give it to everyone, you give it to the high-risk patients. And that's the way we came to be involved in this project. And I think for allied health it's so very important to get involved in these kind of projects, because these devices you will see on the ward, you will see on your ICU unit. And I think that's the way forward, that these kind of problems that inflict patients also involve a lot of different professionals, and all these professionals should be involved in research and using the findings of this research in the daily practice.
Thank you. And then you also commented that you send patients out of hospital with wound vacs devices. And tell us about the communication that you use to make sure that the handing off goes effectively and the device gets managed appropriately.
So this is an important point. I also made a little joke yesterday that all our referral hospitals I can reach by bike in about 10 to 15 minutes, and that's a big difference in the United States. I know that. But we have a good working relationship with both cardiologists, but also the nursing wards in referring hospitals. So you have to make sure that they can reach you. So at the moment we're working on a protocol for a program that they can send photos to us. And if a patient is in problems at the moment, we have a telephone contact, and then if necessary we take the patients back and have a look at it. But more importantly, we went out to the centers and gave them clinical lessons on normal wound development and what a normal wound looks like after 5 to 10 days and when they should contact us, just to make sure that that patient is not treated by his general practitioner or is treated by a general surgeon, but is treated in the center that made that wound and has the most experience with that wound. So communicating not only at the level of surgeon and cardiologist, but also at the level of ward nurse to ward nurse is very important in making that a successful project.
Absolutely, and that after-visit communication was very, very important. We heard quite a bit yesterday from the Duke team about patient safety initiatives and teamwork and how their multidisciplinary collaboration teams have really improved patient safety. And I'd like each of us to kind of comment, what sorts of forums and strategies do you use, Tricia, at your institution to promote communication and patient safety?
We have a number of different things that we do. One of them is we have multidisciplinary rounds. And so when we round on patients, we have the bedside nurse, and the team are the ones who are rounding on our patients with the family members present. And that way we are able to have conversations about what's going on. Any questions or concerns are there. The entire team is there to go over everything with the patient and the family, so there's a different level of comfort. As well, the bedside nurse is there and is aware of what the care plans are. One other item that we do is we have our heart team meetings, and at that time you can also do your M&Ms to see what you did, and we don't just focus on what may have gone bad and how to improve it, but also what went really well that we want to try to figure out how to implement in our standard practice. And we found with these, 2 changes in how we round and how we communicate with each other, we've had a lot of improvement with our communication as a team and are willing to have these conversations instead of just ignoring what may happen. We feel free to discuss things with each other, and that's helped out tremendously.
I think we heard that from Duke yesterday. Just having everybody at the table on a regular basis makes it much easier for people to speak up if they have concerns.
Absolutely.
Joel, could you talk to us about this at your organization?
Yeah, well, I think in medicine we're quite guilty of not getting this quite right. So we're all doing M&Ms, we're all talking to each other about our mistakes, but a lot of us are involved in resus training after cardiac surgery. We're hearing the same mistakes all the time. A VF arrest with pacemakers, the mammary being damaged on opening the chest. There's loads of things that everyone's identifying that are problems that we say, yes, it's a problem to fix, but we don't fix it. And I think we need to take lessons from industry and from the aircraft industry and from engineering, where they iron this out. And I think the key to it's actually training. There was an amazing slide yesterday that shows the percentage training as a proportion of your total job in different specialties. So an athlete's 95% training, a SEAL's 99% training in the military, and even pilots are 20% of their job is training, and a surgeon is like 2%. It's embarrassing. We should all be feeding back after making these mistakes to iron them out by simulation and training. And that, I think we're all guilty of not getting rid of these mistakes, and that's the reason why.
Those numbers are pretty frightening. Tara, what are you guys doing to make sure that your team communicates and improves patient safety?
Well, I would completely concur with what my colleagues have said. Tricia's whole setup framework, you'd be reassured to hear that exactly the same happens in the United Kingdom. But building on what Joel has said, I think that a couple of elements really that need to underpin it. There's a need to be transparent in what you do, and it's not just about us and our team, it's about the patient and the patient involvement right at the beginning of planning and right at the beginning of discussion and selecting where they go and what they do, and then being informed. And I think the whole umbrella under which it needs to fall is around the culture, and it's about having a voice and being heard. And we heard yesterday that burnout means that people feel that they're not heard, their voice isn't heard, they're not important to the process. And if you look at what happens to our patient in their journey, the whole process, the whole journey involves a whole multidisciplinary team, and there's no one person more important in that team than anybody else in order for the patient to be delivered to. And the patient sees people who come to the bedside and from clinics, and it's at that point that we foster a relationship with them. So the whole culture and the learning from education and reflection is very much paramount, and I think the involving training from a multidisciplinary perspective where each other can appreciate each other's strengths and learn from each other is a fundamental pillar on which to build, really.
And Richard, how are things going with you in terms of these patient safety initiatives?
First of all, I'm doing well, thank you.
Thank you.
No, but I'm missing one important thing, and that is we could talk about all these topics and they're vital, but when I look at the Netherlands, that's a situation I can talk about, is that our ward nurses have a minimum budget to do training, and that the surgeons may perhaps have 2% of their time to do training, the nurses have less than 1%, and I think that's very important. We have to train our biggest and the most important group when it comes to peri and post-operative care, and that's the nurses. Surgeons do a vital job, but if they don't get good nursing after the surgery, Joe can do the most amazing things with his robotics, but that patient, even with a flutter back and being discharged the next day, needs a competent nurse who knows what they're doing. And we need to invest in training and make sure that nurses have funds to go to training. If I see the troubles we have in Europe to get nurses to come and visit our symposia and our meetings, it's an enormous problem, and I think that's a very important thing. So M&Ms are excellent, multidisciplinary meetings and talks and things like that. But first of all, we need to make sure that the people that do the daily jobs have the opportunity to learn from their mistakes, but also to learn and grow as a professional. I think that's a very important and vital part.
Thank you. Well, you've all commented on some very important points that I'd like to just summarize. I know at Sutter Health, one of the things that we're trying to do is be both really transparent as well as broadly advertise when we have mistakes or near misses. And we create a format where all of our affiliates share mistakes and we learn from each other. And we've also created a project where, for example, our hand washing rates were down in the 40% range. And we started posting in public areas where everyone can see them, exactly what our secret shoppers were seeing us. And we've now, over a 9-month period, been able to bring hand washing up to over 90% throughout all of our facilities. But again, we never would have done that without that continual feedback and everybody being involved in the project. So I'd like to close by saying that we used a new forum this year at the STS meeting. We were able to create an all-day symposium that had both a combination of plenary speakers, such as some of these guys, as well as some outstanding research abstracts. We believe this forum will continue in the future, so keep an eye out next year when we do our advertising to let people know the STS abstract window is open, and we will have a forum specifically for allied health professionals to submit. So hope to see you next year. Thank you so much.